in your presentation, you talked about health inequalities and sepsis. I guess I was going to ask a question about the Academy of Medical Royal College's publication on initial treatment for sepsis. Are you aware of it before I go? What are your thoughts about the inclusion of health inequalities or not inclusion of health inequalities in that publication and statement?
That's a very interesting question. I think that given that sepsis has such there is really clear health inequality. And I think for too long we haven't considered that as part of one of the reasons that children and adults die. And I think that we need to be more targeted. So I think we're very good at doing CRPs and doing point-of-care tests, but we don't automatically look at our patients and say which of these patients are at risk because of their postcode, because of their education, because of their health literacy. And I think that there is a lot of literature at the moment on health literacy and health outcomes that shows that that so outweighs other things that I think there is a reason to put it in, but I understand your reservations. That's a bit of a mixed answer.
Hello, it's a quick question about MPW. Are there any exclusion criteria in use, for example, somebody who's neutropenic or has leukemia? And second question is there any place they're using it for clinical diagnostics?
So the exclusion criteria, you mentioned correctly that, you know, in acute leukemia, we may have presence of the abnormal monocytes and MDW would be elevated. So we don't have any claims for the oncohematological patients or for the patients with the presence of blast. But from the clinical trials which were done in US, we analyzed separately patients with the blast message on the hematology analyzer. And we found that in that specific subgroup, if we take patients with and without sepsis, MDW can differentiate them well, but cutoff would be higher. So it's different cutoff for that subgroup. And this is why all the literature which has been published on MDW, patients with oncohematological malignancies or patients on the immunosuppressive treatment, in many cases were excluded because this would affect the function of the monocytes. And the second part of your question was? Is it used clinically somewhere at this point of time? Yeah, it's used clinically in many hospitals in Europe and in United States. Yeah, I can, if you need some references, I can connect you with my marketing colleagues who have the list of the sites using MDW clinically. One of them is Badalona Hospital in Spain. They've done trials with us. They use it in emergency department, and also they decided to use it in the ICU to follow up the patient day to day. And when they see increase in MDW, this is indicator of potential nosocomial infection. This patient would need further investigation. Thank you.
Hi, a question for Emma, please. Just because we haven't got the paediatric side of training, I'm one of the CCOT nurses, but we are going to be doing paediatrics. How is the PEWS score changing? Is it going to include the sepsis Phoenix score in it, or is it?
No, it doesn't have the sepsis Phoenix score in it. But there's the other change will be that there is work to look at using PEWS scores in the emergency department rather than previously we were using POPs or Manchester Triage, and that in itself would be part of a screening tool. But there is no national screening tool for paediatrics as it stands at the moment.
Thank you.
Deirdre, sorry. One of the things you said, which I wrote down, is complaints is free feedback. I think that that's really powerful. But I guess how do you recommend that we handle that? Because when complaints come, the first thing is, oh my God. What do you suggest that we react to that, or yeah, just colleagues will be thinking, because that really stood out to me.
Yeah, no, thank you for that. And you know, we receive complaints as well about our service. Okay. So it's, you know, I hear what you say. None of us like to feel, do we, that we've got it wrong. We all try to do the right thing. And there is something, I think, about setting back and making sure that the organisation has the culture where it's not seen as a point of blame, who's at fault, who got it wrong, what happened here. And actually starting from a point that is, as we've heard from some of the other speakers talk with information that's way over my head as a layperson, it's a really complex setting, and as Emma talked about, you're trying to find the one person in the sea of everything to do so. So really, you probably should expect to go into interactions expecting to get things wrong. So when that does happen, it's the opportunity to learn from that. And we heard very powerfully from Melissa as well is when families come to talk to you and they say it's a complaint, take it out of that adversarial space about someone's trying to tell me I got something wrong, and let's just examine what happened and identify where there was opportunity for things to be different. Because, we see frequently the impact on this on families, 2, 5, 10 years afterwards. And what always strikes me when you talk to them is they're still living in that moment. They describe in absolute detail what went on from them, and that they've not moved on from it. So just think if we can move that. Not only are we going to stop having people sat in that position, we can make things better. But I think it's a cultural shift. And as I talked about, I think it's a leadership issue as well. And our complaint standards that is, as I mentioned, free training, offers a lot of help and practical tools to help organisations change.
Thank you very much.